Good afternoon. Our lecture today is about uterine displacement. The objectives of this lecture is to define what is the meaning of uterine displacement and how it is classified, to discuss in details the backward displacement because it is the most important type, explain the etiology behind the backward displacement and what is the differential diagnosis, discuss the methods of diagnosis and treatment, and lastly, to identify the prognosis of the retroverted uterus during a pregnancy. I want to talk you some words about position of uterus. Normal position of uterus is anteverted, anteflexed. That means the body of uterus is directed forward on the longitudinal axis of the cervix, and the longitudinal axis of the cervix is directed backward downward. Supravaginal portion of cervix is relatively a fixed point. So uterine displacement means rotation of the body of the uterus around this fixed point. Usually and normally, the uterus has limited range of movement, and the factors that affect the position of uterus are full bladder, which push the uterus backward, raise intra-abdominal pressure by cuff or bear down, which push the uterus downward, altered posture. The uterus lie lower in standing and lowest in squatting position. We have several types of uterine displacement. It can be lateral displacement, can be backward displacement, in addition to the forward displacement. What we discuss in this lecture is the backward displacement. I mean retroversion, retroflexion. What is the meaning of retroversion? The longitudinal axis of cervix is directed upward backward in relation to the longitudinal axis of the trunk of mother. Retroflexion, the longitudinal axis of the body of uterus is bent backward on the longitudinal axis of the cervix. Usually, retroversion and retroflexion occur together. Such abnormality affect 15% of the women. The etiology of this retroversion or retroflexion can be the following. First, congenital. This type occur in nulliparous women. There is mobile retroverted uterus with short anterior vaginal fornix, shallow anterior vaginal fornix. The cervix is continuous with anterior vaginal wall, and the vagina appear shorter than the average. Second cause can be the prolapse. As the uterus is a prolapse, it pulls the vagina with it, so it is slightly retroverted. Endometriosis can be the cause of retroverted uterus, which cause a fixed type of retroversion if it affects the uterosacral ligament and pouch of Douglas. Fourth cause is the tumors and adhesions. Tumor in front of the uterus will push the uterus backward, or adhesion behind the uterus pull it backward. Puerperal cause of retroversion occur after delivery, when the uterus involutes while the controlling ligaments remaining slacking and subinvoluted. Such ligament is the round ligament. So the uterus will be directed backward. It lasts for 3 to 6 weeks and then corrected to the anteversion anteflexion. If remain retroverted retroflexed, it means that the original position of uterus is retroverted, and such type is also mobile type. Clinical features of retroverted retroflex uterus are the following. Let's start with the septum. In mobile type, it is septumless, and the only risk of such type is the possibility of perforation of uterus if it is not diagnosed by manual examination when we use instrument during diagnostic curettage. In fixed type, there may be spasmodic dysmenorrhea, lower backache and pelvic pain, deep dyspareunia. This is due to the direct pressure on the body of uterus during coitus. So such complaint is position dependent, and the pain can be reduced by change the position during intercourse. Fixed type may cause pelvic congestion syndrome. This arises due to the broad ligament torsion by retroversion retroflexion. So it causes interference with venous and lymphatic drainage and leave the pelvic organs oedematous and congested. It is presented with congestive dysmenorrhea, deep dyspareunia, menorrhagia, premenstrual pelvic pain, and leukorrhea. Retroverted uterus can cause infertility. Why? Because the cervix is directed upward away from the seminal pool, and the ejaculation directly into external os of cervix is less likely. In addition, that the cervix itself may be closed by anterior vaginal wall. Retroverted uterus can cause recurrent abortion. What are the signs that help us in diagnosis of retroversion is the pelvic examination. The cervix is directed upward and the external os is unusually visible easily. The body of uterus is felt in pouch of Douglas posteriorly. Tenderness is a striking feature during pelvic exam. Differential diagnosis of the retroverted uterus can be tubal and ovarian tumor prolapse into pouch of Douglas, mass in large bowel, endometriosis in pouch of Douglas, hematoma or abscess in pouch of Douglas, uterine myoma in posterior wall of uterus. How we prevent retroversion of the uterus of the puerperal type? First, regular emptying of the bladder to avoid over distension so it pushes the uterus backward. Early mobilization, pelvic floor exercise. Encourage the patient to lie with face downward for half to 1 hour, once or twice daily, to induce anteversion. The important time is 10 to 28 days after labor, since before that the uterus is still large, so promontory of sacrum prevent correction. Now we come to the treatment of retroversion of the uterus. The mobile type, because it is symptomless, so no treatment is required, and just reassure the patient that it is normal in position. Fixed type, the treatment is directed primarily to the disease that causes retroversion. What are the methods of the treatment? A. Manual replacement. If the uterus still have some degree of mobility, we can correct it by move the cervix backward, by introduce 2 fingers in vagina and push the cervix backward, so the fundus will be rotated forward and can be caught by the abdominal hand to keep it in its original position. B. Pessary use. This type of a treatment will correct retroversion temporarily, but not cure the retroversion. Hodge pessary is the most efficient type of pessary used. It will introduce into the vagina, so it adds a pressure on posterior vaginal fornix and uterosacral ligament, so pull the cervix backward. It is indicated as therapeutic test. If there is doubt that symptoms are caused by retroversion or not, so insert the pessary for 1 month and ask the patient to report whether the symptom disappear or not. If disappear, that means the symptom is caused by retroversion, so advise to keep the pessary for more 2 to 3 months. In a pregnancy, we can use Hodge pessary if spontaneous correction not occur. C. Surgery. It is indicated in the following. If the symptoms are caused by retroversion approved by pessary therapeutic test. In cases of deep dyspareunia, as a part of operation for endometriosis and myoma, in cases of infertility and habitual abortion. Types of surgery can be Baldi-Webster operation, by hold the loops of round ligament through anterior and posterior leaves of a broad ligament and suture to the back of uterus. Gilliam's operation, by hold the loops of round ligament through internal abdominal ring and suture to the back of rectus sheath using permanent suture. Third type of surgery can be laparoscopic ventrosuspension. Shortening of uterosacral ligament by laparotomy can be done. Now we come to the retroverted gravid uterus. It affects 15% of pregnancies. The prognosis can be either a spontaneous correction. It occurs by the 10th week of gestation in nearly almost pregnancies. But it can be as a sacculation of uterus. If the fundus remains beneath the sacral promontory, so the pregnancy continues by a growing of anterior uterine wall, producing a saccule or diverticulum. If this is not recognized, the body of uterus remains in pelvis, act as a tumor, obstruct the delivery, and the safe treatment is by cesarean section. Third possibility of retroverted gravid uterus, that it causes impaction of uterus. It is also called incarcerated uterus. The fundus of uterus fails to clear above the sacral promontory, and the whole uterus remains in pelvis by 12 to 14 weeks. So the uterus pushes the fundus of the bladder forward and the base backward, resulting acute retention of urine due to the interference with internal urethral opening posteriorly. On examination, there is soft abdominal mass which is a full bladder and may be mistaken that it is uterus. By pelvic exam, it is difficult to feel the cervix because it is drawn high up in the anterior vaginal wall, and there is fullness in pouch of Douglas. Differential diagnosis to such type is the other causes of acute retention of urine, other causes of the tumor in pouch of Douglas as hematocele. The treatment of such emergency complication of retroverted gravid uterus is by admission to the outpatient emergency department, a slow drainage of the bladder while the patient is kept prone in exaggerated Sims position. If this not correct the retroversion spontaneously, so we shall introduce or insert large Hodge pessary. If such is also not to respond, so surgical treatment is indicated. Thank you very much.